Thank you very much and good morning. I'd like to thank the moderators of the session and thank the organizing committee for the very kind invitation to visit your country and the opportunity to give these presentations. It's a pleasure to be here. The first presentation today is what I consider to be probably one of the most important things when it comes to our function in the role as nuclear medicine physicians, and that is reporting. So as much effort as we put into the acquisition of our scans and the performance of our scans, ultimately it's the reports that go out to our referring clinicians that bring value from what we do to the care of our patients. And so over the years, I've developed an interest and have placed a lot of emphasis on reporting practices. At the beginning, I'll differentiate between reporting for research and reporting for clinical ends. Research reporting is generally very structured. You set the rules ahead of time by which the scans are going to be interpreted, and then you interpret those scans according to what those rules are. So it's a very rigid format. In clinical reporting, we have much more freedom to convey what's going on with the patients, to use our expertise to help the clinicians arrive at the best course of management. We have relatively broad interpretation guidelines, and it emphasizes objective measures more than subjective. So there are several elements to adequate radiology reporting, and particularly as it pertains to PET-CT. There's structure, which tends to be very concrete and easy to define, and then there's the content, which is more abstract. There's a lot of information in a PET-CT scan. Obviously, there's all the functional information as part of the PET images, and then combined with all of the anatomic information contained in the CT portion of the examination. So it's very important to have some sort of structure to interpret the study, to be able to dictate the study, and convey all that information in an organized fashion. The three techniques that I've used over the course of my career have been order of priority, anatomic detail, and then list mode, or more of a templated format. And I'll show you what those look like. For order of priority, basically the information contained in the PET scan is listed in the following order. You begin by describing the pertinent PET findings, and those may be things like the primary tumor, nodal metastatic disease, sites of distant metastatic disease. Then you would move into the significant CT findings, which may or may not be FDG avid. So if on a PET-CT scan, for example, somebody has a large pleural effusion that may be resulting in shortness of breath, that would be an important finding to denote. And so that would go in that CT findings section. Then finally, at the end of that report, in the end of the findings section, you describe the incidental CT findings that should go into the report, but probably are not pertinent to the immediate care of that patient, things like gallstones, some focal thyroid activity, etc. This sort of format works very well for cases like this, a patient with newly diagnosed lung carcinoma, and you can see that the report starts talking about that primary tumor, it starts working its way out into the nodal disease and distant disease, and you'll see that the wording that's used in the report conveys the TNM staging that would be required by the referring clinician to decide upon that best course of therapy. So by describing that there's a 2-centimeter pulmonary nodule surrounded by lung, we've essentially conveyed that that's a T1 lesion. We described that there are enlarged lymph nodes in the left hilum and AP window that show some FDG activity, but no contralateral sites of disease. That would denote that that's N2 disease. N1 disease. And then there's focal activity in the left adrenal gland indicating that it's M1. So you can see that by describing all of these findings in the report, the clinicians can then see that this is a T1N1M1 disease or stage 4 because of that adrenal metastasis. I'm often asked, do I actually give a TNM stage? Do I give the stage of disease in my report? I tend not to, just because that's a little bit restrictive in terms of how the clinician may want to manage that patient. So when I dictate these reports, I try to give as much information as I can for them to arrive at that clinical stage, but I don't actually give the stage itself in my report. What I've moved to most recently is an anatomic detail. And so the rationale for this is that frequently the scans contain a lot of information. The findings in this sort of report are broken down into various sections: the head and neck, the chest, the abdomen and pelvis, and then the musculoskeletal section. So my findings section would have 4 different paragraphs for each of these anatomic regions. What drove this is that order of priority that I just described works very well for initial staging. It works fairly well for cases in which the tumor is fairly well localized. But this is the type of patient that we oftentimes see at MD Anderson. And if you had to look at this scan and say, what is the most important finding? What are you going to talk about first? It's difficult to say because there are so many sites of disease that need to be detailed. And so having this anatomic structure provides a framework to work your way through the examination, to start talking at the head and neck, then the chest, abdomen, and pelvis, and MSK. And it gives that framework to allow a very organized and regimented way of interpreting the scan in the face of fairly extensive disease. So you can see that each of these individual paragraphs may be fairly lengthy, but contained within each of those is vital information for the overall staging and care of the patient. Over the last month or two, I've made a little bit of a transition and become a little bit more exploratory with this last mode, and that is more of a tabular or fully templated format. This is truly the templated format where you detail each of the individual anatomical compartments and describe the findings that may or may not be present. It's broken down by anatomic region and by organ and system, and the goal is to keep this as succinct as possible. This is a type of template that's been used for years in things like ultrasound and CT. So for example, an abdominal CT scan, it's fairly easy because there are fairly limited choices in terms of what you're going to describe, the liver, the spleen, the pancreas, and it's easy to go down that list and describe the findings that may or may not be present. With PET scanning, though, if you do our typical PET scan from the orbits to the thighs or the vertex to the thighs, you can see that there are a lot of different anatomic regions, a lot of different organ systems that would be required to detail in this report. So that tends to be a little bit off-putting. However, like I said, in the last few weeks, we've actually made a transition at MD Anderson to voice recognition software. It's allowed us to use these templates and pre-populate the reports with standard terminology and then only have to detail the areas that vary from that standard template. And so this is a report you can see just from earlier in February, a case that I dictated. It was a contrast-enhanced PET-CT, kind of showing what this report looks like. So it very well details the criteria. We're an ACR-accredited facility, American College of Radiology, that requires us to detail the radiopharmaceutical, the amount of activity administered, route of administration. You can see this is all just templated and very well laid out as far as what's in it. In regards to the PET report, then, you can see that these fields are all pre-populated. And only in cases where there are significant findings is there a dictation that overrides that pre-population. So for example, in the mucosa of the head and neck, the standard report template would say that uptake in the head and neck mucosa is normal and symmetric. If, for example, there is a lesion in the head and neck mucosa, then I would dictate over that and say focal hypermetabolism in the left tonsil, etc. So it's a lot of information that gets incorporated in this, but it does provide a nice framework for working your way through the complexity of a PET-CT scan, making sure that every single organ system is interrogated with both PET and CT findings. Despite the length of that findings section, though, you'll see that the impression is actually quite short. And this is always what I strive for. The clinicians are busy, and so if they are rushing, they're seeing patients, and they want to get to the bottom line, they'll in fact many times skip that entire findings section and go right to the impression. They want to know what is the bottom line of this report. So you can see, despite all of the findings that were present in this, the report is quite short. And in this case, it was a patient who's being followed up for lymphoma, significant positive response to therapy with resolution of the multiple sites of lymphoma seen on the prior examination. There is currently no evidence of residual viable lymphoma. So that's that kind of one or two sentences that lets the clinician know what the bottom line of that study is. So that brings us to the impression, and this, if anything, is the most critical portion of any radiology or nuclear medicine report. It's where we summarize the findings that are contained in that first part of the section and let the clinicians know, here's what's going on. Here, in my professional opinion, is what you need to know about this scan. The goals of the impression section are that it should be brief and concise, and most importantly of all, answer the clinical question. In general, scans are ordered, or they should be ordered, because there's a specific question that needs to be answered. That question may be as broad as, what is the status of disease in this patient? What's the initial stage of disease? But it may be something as specific as, this patient is having chest pain. I've done a CT scan or a bone scan and I don't see anything. Does PET show me any information that would indicate that this is due to malignancy? If we know that that's the clinical question, we need to make an effort in our impression to specifically address that concern so that the clinicians are deriving value from the scan. We should strive to give a precise diagnosis. When a precise diagnosis is not possible, a clear and organized differential diagnosis should be given. And it is appropriate to discuss the use of additional imaging if you think that that would be appropriate to eventually arrive at the correct diagnosis. So in terms of a framework for reporting, I like to refer to these 8 C's of reporting, and this applies to any sort of radiology reporting, but particularly for PET-CT, and this comes from an article by Bruce Reiner and colleagues. The 8 C's are correctness, completeness, consistency, communication, clarity, confidence, concision, and consultation. Now, correctness you'll see is at the top of the list, but ironically, I think this is actually one that I de-emphasize a little bit. We obviously all want to be correct in the way we report our studies, but correct reporting does not always mean that we're getting the correct diagnosis all the time. And I'll use this as an example. This is a patient who came in, had a spiculated upper lobe pulmonary nodule. PET-CT was performed that showed this nodule was hypermetabolic, and a biopsy was performed. When the biopsy results came back, it showed non-caseating granulomas and aspergillus. So this is, in fact, an aspergillus infection. But the report in this case, I think, is correct. When faced with a hypermetabolic spiculated pulmonary nodule in the absence of other information, one has to make the assumption that this is potentially a malignant finding and a biopsy should be done. So the care of this patient occurred in the correct fashion. The ultimate diagnosis was not correct, but nevertheless, I believe this is an example of correct reporting practices. Completeness and consistency are important, and those can be helped by reporting templates, as we just discussed. And there are several different articles, including this by the Society of Nuclear Medicine and Molecular Imaging in the United States, that details some of these report templates that can help you with your consistency and completeness. The last 5 then, I think, can all be summarized under the heading of communication. As I said at the beginning, the goal is to communicate our results in a clinically relevant fashion. And in order to do that, these last 4, clarity, confidence, concision, and consultation, really come into play. Now, these get a little bit more esoteric and a little bit harder to define, but I'll show some examples of things that I see in PET reports commonly that illustrate these. So the first of these is a patient who had a PET-CT scan, and we see some focal activity along the right pelvic sidewall. And the impression in this case said, single punctate focus of mildly increased metabolic activity along the posterior margin of the right ovary without finding for a definite mass on CT. The remainder of the study is unremarkable. Now you can imagine if you're in the role of the clinician getting this report, your question is going to be, well, what do I do with this? What does this mean? This is not really an impression, it's a description of a finding. And we've not really given any guidance in terms of what we as the imaging professionals feel that this activity denotes. Do we think this is merely just physiologic activity in a young woman? Is this potentially a primary ovarian carcinoma in an older female? We've really not given any guidance, and so this is really a lack of clarity in this case. We've not conveyed what our meaning is. Another common pitfall I see with PET-CT scans is using the SUV as an impression. So the SUV is a great descriptor. It conveys the intensity of activity, but in itself, it's not a diagnosis. There are many different malignancies, many different benign conditions that can all result in an elevated SUV. So a report like this that says there's focal activity in the left hepatic lobe with an SUV of 6.5. There's hypermetabolism along the floor of mouth with an SUV of 10.2. If we think that that degree of activity and the configuration of the activity is such that malignancy is a consideration, then we need to come out and say, we think this is a primary malignancy of the floor of mouth. We think this is a hepatic metastasis. Those are diagnoses. Description of SUV is just that's exactly what it is, a description. And so again, illustrating lack of clarity, but this is something I do see with some frequency. Another thing that I see in radiology and nuclear medicine reporting in general is overuse of qualifiers. Now, we all need to use terms. Nothing is set in stone, and it's very seldom that I sit down and look at a PET-CT scan where 100% I'm confident that this is what the diagnosis is. There's oftentimes some debate and a differential diagnosis. But nevertheless, using these qualifier words too often can lead to a lack of confidence on the report of the referring clinician. So I use this example of a report that says likely active metastasis, probable treated disease, non-specific activity, likely a sebaceous cyst. You know, these sorts of words kind of convey that we're not really sure what we're looking at, and their overuse can certainly lead to a lack of confidence in our report. As I said, we oftentimes need to give a differential diagnosis because the findings that we're seeing on the scan may not be 100% diagnostic of what we are considering in our minds. But nevertheless, take a look at this report. So we see a scan here with some activity in the lungs delineated in the hilum and the adjacent pulmonary parenchyma. The report in this case said hypermetabolic right lower lobe pulmonary mass with associated hilar masses and small focal hypermetabolic precoronal and left hilar lymphadenopathy. The appearance is unusual for metastatic disease. However, tumor cannot be excluded. An inflammatory or infectious etiology is possible, and an unrelated neoplasm, such as lymphoma, also cannot be excluded. There, we've given a differential diagnosis, but we've just kind of laid it all out there in terms of what the possibilities are, really providing no direction. Again, as the imaging experts, we should be able to look at a scan like this and, be it through the imaging findings, be it through the clinical history, perhaps arrive at some sort of direction for the referring clinician to say, I feel that this is most likely A, it could possibly be B, and if that's the case, here's what I think should be done next. Giving some sort of direction, but just listing all the possibilities in a differential diagnosis with no direction and no indication of what we feel is the most likely, again, provides a lack of confidence. Sometimes we'll see reports like this, and this comes from the fact that PET-CT scans can be very complex with a lot of different information. This is actually one of my reports from my earlier days where the impression was quite lengthy. And you can see that I had a lot to say in this report. But what I've learned over the years is when you feel like you have this much to say, it's probably best to pick up the phone and talk to the referring clinician because this becomes a conversation. This was indeed a very unusual case of a patient with esophageal carcinoma, some infiltrating disease in the liver. It all did just turn out to be metastatic disease. But again, what I've learned over the years is that this sort of impression, as I said, gets to be overwhelming for the referring clinicians who want to know what the bottom line is. And I've discovered over the years that they much prefer a phone call when there's this much to be said. So this illustrates a lack of concision, lack of being concise in the report. Finally, here's a scan with a common incidental finding on PET, some focal activity in the prostate gland. The description of the report said new mild focal activity in the right prostate gland is nonspecific and could represent focal prostatitis versus malignancy. Clinical correlation is needed. The question in this case is when we say clinical correlation is needed, what sort of clinical correlation are we thinking of? What could be done to differentiate focal prostatitis from occult malignancy? And the answer to that is not clear to me. You know, PSA may be elevated, it may not be elevated, there may be a palpable abnormality in the prostate gland, there may not be. I'm not sure that any of those would reliably differentiate whether this is in fact focal prostatitis versus prostate carcinoma. And so by saying just clinical correlation is needed doesn't really provide any guidance and certainly doesn't provide consultation. Again, we as the imaging experts need to convey what exactly this finding means. I'm going to finish up in the last few minutes just talking about a few additional topics when it comes to PET-CT reporting: language, trajectory, magnitude, and the big picture. Starting with language, it's just a quick reminder that fundamentally PET-CT, like any other imaging study, when we're dealing with the cancer patient, needs to be binned into these categories, and I'll mention this in one of my later reports as well. We use RECIST 1.0 and 1.1 with CT reporting, and the language that's been developed has been complete response, partial response, stable disease, and progressive disease. So our clinicians at MD Anderson, when they order a PET-CT scan and follow up of patients with malignancies, do expect to see these categories in our reports. They basically want to know is the tumor same, better, or worse. So that should be one thing we strive for with our reporting. And so here's an example from the literature conveying early response of a patient with lymphoma. We can see that the disease on the initial scan resolved almost completely, even on day 1 following chemotherapy, and this turned out to be a sustained response, so a complete response to therapy in this case. Trajectory is a very important concept. Understanding that the sum of small changes can be additive. So one of our pitfalls at MD Anderson is that we do tend to image patients fairly frequently during the course of therapy. And if you look too closely, if you're looking at scans that are fairly close together, you may not be able to appreciate small changes taking place. And so when I look at a scan, I try to pull up several of the prior PET-CT scans so I can see not only what's happening today and on the prior scan, but perhaps the bigger picture in terms of what's taking place with regards to the patient. So using this as an example, patient with metastatic breast carcinoma, this is the current scan, and it was compared to the prior scan, and the report said stable disease, widespread osseous metastatic disease with no significant change in the interim. The previous scan had been compared to the prior scan, and it said about the same thing. There was widespread osseous metastatic disease with no significant change since the prior scan. But if you put up all three together, you can now start to appreciate that there are subtle changes that are occurring from scan to scan that become most conspicuous when you compare the older scan to the newest scan. For example, this lesion in the proximal humerus, which was relatively low in intensity, increasing in intensity, and now is quite intense. And in fact, when you go back and compare to an even earlier study, it becomes even more striking. So when you look at the individual scans, what may appear to be just some minor fluctuation in the extent, as you add that up over the trajectory of the patient's disease process, you can see that this is in fact slowly progressive disease that's not responding to therapy. Magnitude is very important. So we need to convey the degree of response or the degree of progression. And this may be a verbal conveyance. We could say things like a marked progression of disease or a moderate decrease in the intensity of activity, slight, minimal, all of these adjectives that we use to convey the degree of response. But the problem is there's a lack of standardization. SUVs, there's actually quite a bit of debate about. Some people use them, some people don't use them. I think at the very minimum, the SUV can be a very good adjective to describe the intensity of activity. So for example, an SUV of 20 going down to 5, we know that that's a very good response. An SUV of 8 going down to 6, that conveys a moderate response to therapy. So I do tend to use SUVs quite frequently as a descriptor of intensity for this very reason. So for example, in this case, we can see this is a positive response to therapy, but there still is substantial residual tumor even on the post-therapy scan. So do we call this a partial response to therapy, a moderate response to therapy? A phrase that I tend to use fairly frequently is positive response but with residual viable tumor, indicating that if treatment were to stop after this scan, in all likelihood that patient would recur and progress. Finally, the big picture. So PET-CT does have its limitations in terms of its precision, and it can be things like blood glucose, localization time, fasting. Some of these are in our control, some of these are not in our control. There are things that can show activity on PET scanning that are not related to malignancies, such as lymphoid hyperplasia, sarcoid, etc. When there's been a complete response to therapy, that's an easy call. Disease has gone away. When there's progression of disease, that's an easy call as well. We can see new sites of disease developing, existing sites getting bigger and brighter. The more challenging cases are where there's stable disease or either slight positive response or slight progression. And again, looking at overall trends can be helpful. So going back to our graph of response, we can see that here are the 4 categories. But it's not always this clear. So take a look at this case. This is a patient with desmoplastic small round cell tumor. It's a small round blue cell tumor type. And you can see on the initial scan, the patient had an SUV of 10.9 in the hottest site of disease. This went down to 9.5 with therapy, and that was called a positive response. The patient comes back, the SUV's gone up to 9.9. This was called progression of disease. Then it's gone down to 9.2. So at each scan, we're saying it's getting better, it's getting worse, it's getting better, it's getting worse, and it drives the clinicians a little bit crazy. What's happening in this case is that we're kind of bouncing up and down above that mean value. So it's important to remember that stable disease can in fact be a cone. It doesn't imply that the disease is exactly the same from time to time. We can have a little bit of fluctuation due to these variable parameters in PET scanning. So here's a phrase that I use fairly frequently in our patients with advanced disease. There have been slight fluctuations in the extent and intensity of disease since the prior examination, but no significant progression or regression of disease has occurred in the interim. With our newer therapies, which tend to be less cytotoxic and more cytostatic, this is oftentimes the picture that we see, is that the disease will fluctuate from time to time based on patient-specific parameters or scan-specific parameters. And so it's important to denote that even though the disease may be fluctuating, ultimately if the patient has gone 9 months and has gone from this to this, that's relatively a therapy success. We've held that disease in check over a fairly long period of time. So in summary, clinical reporting is different than research reporting and gives us the opportunity to convey our professional opinion in order to guide the clinical care of the patients. For that to occur, communication is vital, and using those 8 C's of effective reporting can be a helpful guideline in terms of taking all of the information, the complex information in a PET-CT scan, and distilling it down to a final message for the referring clinician. Using reporting templates can help, particularly with consistency and completeness. But don't forget the big picture. Remember that this is a patient, and ultimately we're trying to give the clinically relevant information that will allow our referring clinicians to institute the appropriate management for that patient. Thank you.